Well, good afternoon, everyone. It's 12 p.m. Eastern Time, and we'll go ahead and get started with the IUSD webinar today. My name is Bradley Stoner. I'm at Queen's University, and I'm also the membership secretary for IUSD Canada. It is my pleasure today to welcome our webinar speaker, Dr. Patrick O'Byrne, who is going to be speaking about the GetaKit project, at-home HIV self-testing and STI expansion in Ontario. Dr. O'Byrne is a full professor of nursing and a licensed nurse practitioner at the University of Ottawa. His clinical and research work focus on the prevention and diagnosis of sexually transmitted infections. Dr. O'Byrne operates a nurse-led HIV PEP and PrEP clinic and is the principal investigator for GetaKit. I want to welcome today Dr. Patrick O'Byrne.
Thank you. Thanks for having me and for everyone coming. I'm just going to share my screen. There we go.
I just want to remind everyone that the webinar is being recorded and with Dr. O'Byrne's permission, and this will be posted later, and we'll have a link for that on the IUSD Canada website.
Thank you. So I want to thank everyone again for coming. GetaKit is something I thoroughly enjoy talking about, and so I'm happy some people are interested to listen about it as well. Just as was said in the introduction, I'm a professor of nursing at the University of Ottawa. I'm also a practicing nurse practitioner in the STI clinic operated by Ottawa Public Health, where, I mean, with all things being COVID, we did have reductions, but maintained looking through to 2021, seeing probably around 8,000 to 10,000 people still in person. So a very busy STI clinic. And so really what GetaKit is the output of my research and my clinical work, the effects of COVID, just sort of the ongoing landscape with STIs and HIV transmission and diagnosis and everything we've learned. And so this really just sort of it coming to a head. So starting with disclosures, funding, I have from the Ontario HIV Treatment Network, the Ministry of Health, Government of Ontario, Health Canada, CIHR, conflicts of interest, I have none to disclose. So the background, HIV, what do we have across Canada? We have what looks like sort of from the last year of what I would call normal data, right, pre-COVID, where we didn't have effects on closures of health systems. We had across Canada what looks like a decrease, but in fact, if you really look across that bar, is a return to the rates and numbers we had sort of pre-2016. So there was a bit of an increase that's gone back down. In Ontario, specifically where I'm running GetaKit, you have more or less stable HIV numbers. And this is really an interesting point because despite all of the excellent work we've done, right? We have peer-based testing, we have outreach testing, we have testing in emergency departments, primary care facilities, urgent care facilities, STI clinics, all of these different things, right? Really what we've been able to accomplish with this is relative stability, which says that we're doing a good job at preventing things from actually increasing and right, going anywhere. But in getting ahead and right, really pushing down sort of becomes what are the new things we can do? What are new ways we can do it? Right? How can we actually push beyond just sort of the status quo? We also have, and these are from 2018, both national, so on the top, and then Ontario for the bottom, we still have around 13–14% people who are estimated to have undiagnosed HIV infection. And so you have a percentage of people that just are unaware of their HIV status. They are HIV positive, they don't know. This is, I mean, at this point, we still had the 90–90–90 goals. And so in both cases, both across the country for 2018 and in Ontario for 2018 as well, we're below that threshold of right 90–90–90, meaning right 90% of people being diagnosed, 90% of those being on treatment, and 90% achieving undetectable viral loads. And you can see relative stability across Ontario plus the national data for 2018. Now, we would have hoped that time moving on that we would have been able to make improvements on this. We passed 2020, right? So the 2030 goals are now 95–95–95, but we had major social, economic, health system, just worldly disruptions due to COVID. And so what we've actually seen is a decrease in access to testing and diagnoses. So in Ontario, you can see 2020, there was around right a quarter in the drop of the number of tests across the entire year. That will average out, right, of the beginning, the first few months, right, pre-March, and then you're going to have sort of the March through May where you'll have the deepest decreases, but this average out the whole year. There's also then a corresponding decrease in number of new diagnoses, corresponding with almost the exact amount of testing that's down. Now, does this necessarily mean that we missed a whole lot of infections? That is possible. There's nothing really that can tell us otherwise. However, with increased uptakes of PrEP that we're leading up to this point, with decreased actual migration going on during that time, right? So fewer people coming from international settings to Ontario, it's possible that there was actually just a true decrease, but the decrease in testing may have also contributed to that. And this is something that I think time is going to tell for us. It may actually impact, right, that ability to say how many people still have undiagnosed infections. Now, not everything was bad during COVID and the effects for HIV testing. We also had the first HIV self-test actually licensed in Canada, and this is the STI test. And so in November of 2020, we had actually sort of Health Canada approved access to HIV self-tests, which people could purchase, right? You'd be able to get, you could distribute in projects through programs, through innovative studies, whatever it happens to be, you were able to get them. But this unfortunately does come with a single caveat in that they are actually expensive. So what that costs there is if you were to order this in Ontario, right, basically I'm in Ottawa, if you were to ship this to Ottawa from right where it's coming from, the cost of this is going to be around $55. We are well aware that many people who are affected by HIV, that is right, just limiting access, right? That is sort of exorbitantly expensive for them to actually be able to get access to it. And so we do have the self-testing, but there are some barriers still, right, that we're going through. So what does that lead us to? It leads us to GetaKit, right? And what's the context, just to summarize everything we have there? We really have a context that is ongoing unabated HIV diagnoses. We have decreased access to healthcare. During COVID, we have the availability of self-tests, and we also have, right, despite these self-tests being available, we do have, right, limitations based on the actual cost of the test. So our starting point becomes that test that you can order, right? That $55 test that we were looking at that you can get, right? But that, as you can see the components there, you do get the lancet, you get a Band-Aid, you get the vials, the test device, right? It comes with the basic requirements. But HIV testing, right, restricted down to that, can give you the test, it can give you the answer, but there's lots of pieces missing. So what we did was, starting with that kit, our first step was really to build ourselves a package and a box, collaterals, pieces that we could put around it. And so I have the box laid out there, and just to show you really what it looks like beside my head, this is the size of it. And you can see it really on the outside has absolutely nothing saying that it has anything to do with HIV, right, other than this hello aloe. There's really actually no writing whatsoever. And the blank parts are just to put a Canada Post shipping label. So that's what goes over the components there. So we built this box, and inside it, as you can see on this, we distribute as well condoms, lubricant, the test itself, information on HIV, information on doing the self-test. And what we also created was, you can see it's actually in both images, we created what we call a workstation, which is a little pop-up disc where people can actually insert the test device, they can put the vials. The STI test is highly accurate, right? The estimated pooled sort of sensitivity of it after 12 weeks, 99.9%, right? So its ability to detect is basically, it's going to miss 1 in 1,000 after 12 weeks. So it's exceptionally good. But it does have a lot of pieces, right? You have to have the lancet, you have to clean your hand, you need to get the 3 vials, you need to have the test disc, you need to do everything in order. So one of the things we really wanted to do as part of this was also create a way for people to organize themselves and have a little workstation. And this evolved. Originally, it was built into it, and then we did the pop-up. And the pop-up allows us to have additional print information here, which walks people through, right? So they actually have a visual that they're able to look at, right? That's giving them reminders and key points and sort of items that we have found throughout the project that can help people actually do the study itself. And in the end, as I said, it folds up into, right, a box that sort of is relatively small, will fit in Canada Post boxes, doesn't need to be left out, and is discreet and secure so people can actually order them. So those are the pieces, right? That's really where we started. We started with the INSTI, we built the collaterals, and then we moved into building an actual website. Because how can you get tests to people during COVID? People can't be coming necessarily to centers. They can't be filling out on-site sort of completion, registration, risk screening activities, right? Everything, we had a huge amounts of closure. And so we built GetaKit.ca as the actual website that people could go on, where they can register, they can put in their information, they can complete a risk assessment, right? And so we sort of built this platform. Now, in the back of the platform, and I have eligible just in a red box because I'm going to go into it a little bit more in a moment. But basically, what we built was a workflow, right? What happens as somebody logs on and goes through this process? What's the flow going to be as they move from step to step? So the individual hits the site, they register. If they don't register, right, that's the end of the process. Then they complete a self-assessment. The self-assessment is going to screen them in or out for HIV testing. If they're screened out, it's going to give recommendations based on sort of the risk profile, saying like where you could get testing, don't forget about other elements, STI testing, right? Other pieces of prevention that might be necessary. If they are deemed eligible, then they are given the ability to order a test. If they opt out at that point, that's the end of the road for them. If they say yes, then it goes into the kit being processed, it being actually shipped out, and our follow-up for results reporting. The system is automated to actually send out reminders asking about results reporting. This occurs at day 10 and 17. And really what it is we're assuming that worst case, it takes 3 days for a kit to actually get to somebody. It's usually sort of within 1 to 2 days that the kit will actually arrive anywhere in Ontario. And we'll actually, with curbside pickup that people can do, we do have stashes, like pockets of kits in different areas. People could actually go to, for example, the Sexual Health Clinic in Ottawa, participating pharmacy, some of the AIDS service organizations where they could say, right, I've ordered a kit, and they go and do their pickup. So it could actually be same day, like almost immediate. But the 10 to 17 is really at 1 week and 2 weeks. We do a follow-up just to say, hey, do you want to report your result back to us? If the person reports an invalid result, they are given information on, right, how do you get an invalid result? What are some tips to prevent that from occurring again? And they're encouraged to reorder, given instructions and sort of linkages over to reorder a test. If the result is negative, the person is then stratified based on their risk assessment into a priority population or into a non-priority population. And the priority populations, basically Ontario across the Canada, right? Gay, bisexual, other men who have sex with men, individuals who are trans, members of African, Caribbean, or Black communities, members of Indigenous communities, people who use drugs, people who come from areas where HIV is endemic. There sort of is a non-exhaustive list in case I missed one in just saying that. But those groups will get a message talking about linkage to PEP and PrEP and where to go to get it, and a reminder for the retesting at 3 months. Those who are non-priority populations are just given information basically on other testing and window periods in case additional testing is required. And this is really just to follow screening and testing guidelines that we have Canada aligning with the United States CDC, Ontario guidelines as well. People who report positive results, the system actually will immediately notify the GetaKit team. So people working as part of the project will immediately be notified, right, that a positive result was reported. So we can log on to actually look at the system, right, see who it is and initiate contact. The system immediately, it is dynamic. It will immediately, as soon as somebody does that, it will give information on supports for mental health, crisis, the need for confirmatory testing, considering this a preliminary positive. It does have, again, the specificity of 99.5%, the INSTI kit, which means 5 in 1,000 false positive rate. So if you have a high enough pretest probability, right, you belong to a group that's disproportionately affected by HIV, the chances that this is going to give you a false positive are slim. And so our approach is, right, we will consider these true positives until ruled out. And so information is given on HIV transmission prevention disclosure, speaking with the HIV/AIDS Legal Clinic of Ontario. And we will reach out within a business day as well to ensure people get linked to confirmatory testing, right? And it's usually almost instantaneous that we'll reach out for that. Now, this eligibility part, let's just go back to that, where the eligibility is. How does this actually occur? It's this effective risk matrix. This is relatively simple to use when you're a clinician. The human mind can get its sort of ability to use this, right, pretty simply. The computer is a bit more complicated as we attempted to automate this, but basically the risk matrix which we have here, which is a heat map, right, moving from low to medium to high risk as you move diagonally across, really says along the x-axis, the risk of transmission per, right, sex act, what was the actual risk? And then along the y-axis, it's what's your actual probability of exposure, right? What's the chance that you actually came across somebody who was serodiscordant? So you are HIV negative. What is the probability that the person you had sex with or shared drug equipment with, right, is serodiscordant? So you're negative and they're positive. Then again, the x-axis being, were an exposure to have occurred, what's the probability that transmission would have occurred right in that actual instance. And really what you do is you just plot the intercept, right, of those two risks, and it puts you into low, medium, or high risk. That for a clinician is, or somebody working in the field, somebody who's doing risk assessments, this is pretty straightforward, right? Were you a member of the population? Do we know that the person that you had sex with, right, is HIV positive with a transmissible infection, right? So not that they're HIV positive and undetectable, but right, we have transmissible infection being present. And what was the sexual practice, right? Was this just watching? Was this mutual masturbation? Was this, right, penetrative sex, vaginal, anal, top, bottom, condoms, none, right? When we move people along and then you just sort of plot it out. Now, automating that into the computer system required coming up with basic thresholds in a point-based system. And so really when we went through it, it was to say, right, what do you do? And you accumulate points, right, as you have risk factors. And then we had to map out the actual math and equation to figure out, right, for the populations. Now, what's interesting with that, and we published it in this article, was going back one, while the x-axis, so your risks based on sexual practices, was pretty linear. It just was like sheer addition, right? If you have condomless vaginal sex and you have condomless anal sex, right, it just adds the points for each of those. But the populations were not. They're actually, they're exponential in the way they go up. There was a quadratic formula we had to come up with to actually make this work. And first approaching it, it didn't dawn on me, but once we sort of figured out how to actually make this work and follow the guidelines, in retrospect, it makes perfect sense, right? If somebody identifies as being, right, a man who has sex with men, right, you're not going to go necessarily from 0 risk to 1. And then if this is a man who has sex with men who is a member of an Indigenous community, it's not going to be risk to risk 2. It actually goes up exponentially. And so really what you move from is a baseline of 0 to your first risk point becomes 10, and your next risk point actually becomes 100, right? So it's really going up quite dramatically, which makes sense when you think about it, right? Because as you layer on risks, right, when it comes to, right, the populations that are most affected, it's not just that it's climbing, right, in sort of a stepwise fashion, it's really, really ramping up, right? So you have the person who says, right, I am a gay man, I am Black, I came from a different country, I use meth, right? Adding those layers in, we're like, okay, well, you're not just like a little bit more at risk than, right, somebody else, right? There's a lot of factors there. There's a lot of social items at play. There's a lot of power dynamics. There's a lot of mental health and social support, right? All these different factors sort of layering in continuously. They're intersecting to make this risk level much, much higher. And so when we really figured that out, now we were able to get the system to actually start calculating the eligibility and screening people in and out according to available guidelines. So once we had that entire system built, as you can see, there was a lot of background that went into it. We implemented in 2 phases. And phase 1 was the pilot phase in Ottawa alone, starting July 20th. And you'll see that actually started before Health Canada's full approval. And we applied for special access to Health Canada to say, we are in deep COVID. People are unable to get tested right now. This device is going to be imminently licensed by you. Would you let us use this? Basically as a pilot project to figure out, right, if we distribute these, what are the outcomes? How do we do it? And it really is to tweak and tailor and improve the system, knowing that, right, it's coming. So rather than waiting for the approval and saying, okay, now we have this, how do we crash land our implementation? We really started as a small pilot to say, okay, we've got this. And knowing that this product will be approved imminently, how do we actually build things, learn, make corrections, make improvements so that when we do have the licensure, and we can more readily distribute, how can we be ready and actually have a system that's quite robust and able to work? So then, right, we moved to phase 2, which is the Ontario-wide expansion and implementation. You can see in the table all the different sites we have across the province, and those are specific aid service organizations that do linkages. There is nowhere in Ontario where somebody couldn't order a kit. They would be able to order it and we would be able to distribute there. And the central sort of Ottawa hub team will do the management, right, for linkages to care, for follow-up on negative results, for people who need local support for PrEP, for people who have positive results, who are looking for confirmatory testing, linkages, right, everything that they would need for that. So the outcomes, actually, before getting to the outcomes, what I would like to do is in that, let's just actually look at the system itself. So I'm going to load it up. So I think, can you guys still see my screen? I believe that's.
Yes.
Yes. So when you land on GetaKit.ca, there are all the different hub squares, right? These are all the different partner groups that people can log into. And this really what occurs in each site is it's got the color schemes, it's got the resources, it has the support, and it has management coming from the local agencies. For Ottawa, just the one to go through, right? We've seen this image on the actual deck. An individual who comes for the first time would select register. It has the actual research consent form, right, for us to do the full data collection. Then it has the digital risks, right? This is an online system. It says, right, keep your password secure. If you do share it or there's a breach, let us know. We do everything to keep your information private and secure. This is a Canadian-based system. No information leaves, but right, any system is viable and has threats to it. Don't share your personal information, HIV, right? Don't disclose your status unless you speak with HALCO. And if you have symptoms, please go and actually be seen by a clinician. Self-testing should not replace clinical services, particularly if you have any symptoms. Then an individual goes into the registration, they create their password, they create their account. Now I already have one, so I just log in. It uses a two-factor authentication. So I just need to get my code. Oops. 4, 5, 5. Okay, so then I verify my code and I get myself in. So I have my order history. The ability to do my account settings, manage clients, and the WordPress admin, that is really just because we're in my actual account. And so this eligibility screener, right, I can just say I'd like to order a test, sorry, and then it confirms my address. This is the sexual health clinic. I say, yes, this is correct. And I move into the next question, which is a few questions of a safety screener, right? Is it appropriate for somebody to do at-home self-testing? So first one is, do I have any symptoms? If I say yes, it's going to ask for confirmation, and then it will say, if you have symptoms, right, you should link with your local services. And depending on the actual site that somebody's gone through, it will give them a list of resources. So I'm going to say no. And the next is, any partners, is anyone you had sex with recently diagnosed with any infections? And I can say yes, right? HIV, gonorrhea, chlamydia, syphilis, none, or I'm not sure. So I'll say somebody had sex with was recently diagnosed with syphilis. This is a question about emergency contraception and HIV post-exposure prophylaxis, more giving information than anything else. So I'm going to say, nope, this won't kick somebody out, but it's just more for information. Bleeding disorders. So Health Canada actually in the product monograph says people with bleeding disorders should not be using the INSTI. So this would be to screen them out. So I'm going to say no. Taking part in an experimental HIV vaccine research study. This would apply to very, very, very few people, but just in case there are experimental antibody studies going on, we're not entirely certain how this test would react. So a yes would again remove the person. Are you currently taking PrEP? Now, PrEP is not going to be in and of itself an exclusion criterion here. It's really going to say, if the person says no, it will allow them through. If the person says yes, it's going to say, are you doing follow-up per Canadian guidelines, which would be, right, the every 12-week follow-up for HIV serology and your kidney function test. There are a number, I believe it's probably small, but I do see this clinically quite often, a number of people who are prescribed PrEP, and they do annual follow-up with whoever their prescriber happens to be. And so knowing that they're on PrEP is good, but knowing that they're not doing HIV testing at sort of the recommended guideline interval would allow the person to go on. So it's going to say, are you on PrEP? If yes, right, are you doing follow-up for the guidelines? Right? And it won't word it that way, but it'll just say, right, at this frequency. And if the person says yes, and it says, if you think you need HIV testing done more than 4 times a year when you're on PrEP, please go and see your PrEP prescriber and have a conversation. But if they say no, it will let them through. So I'm just going to say no to skip those questions. Next is questions on race and ethnicity. We put in a bit of text in the background here, and this was a discussion with our partner organizations on whether or not to have a prefer not to answer. I would really like to say, everyone, I would like you to report your race and ethnicity based data. But speaking with our sort of partner organizations, they're saying not everyone, not all of their members were going to be comfortable with that. It may actually deter some people from using it. So there's a bit of a preamble that says this is why we need the information. It's really that if we find that despite members of African, Caribbean, or Black communities being disproportionately affected by HIV, if they're coming in right at exceptionally low rates of usage, it tells us we really need to do more outreach and expansion and figuring out how to maybe even make the system more culturally sensitive to actually get people engaged. So I'll say white. Next is sex and gender. So I'll say that, I'll say is a cis man. I'll run through as just a white cis gay man, guy who has sex with men. For sexual orientations, I prefer not to answer. Ever sexually active. If I say no to this question, it will jump to drug use. So I'll just go through yes, sexually active. With cis men, I'm going to have the ability to select more. Are any of my partners, right, belonging to sort of other groups that are disproportionately affected by HIV? So I'll say some are HIV positive, some are bisexual or pansexual. Anatomically, what do I have? The question I'll put, I have a penis. Sexual contact, so received oral sex, performed oral sex, anal sex, top and bottom. Condom use, so never. Any sort of sex work, exchanging drugs or money for sex or vice versa. I'll say no for sex work. Have I ever been tested before? If I say yes, it's just going to ask when. So I'm going to say no, just to skip through that. And any drug equipment sharing. So I'm going to say no. Now, what it does, and ignore this red box you can see in the bottom of my screen, that's just the debugger in case something goes wrong in the process. So really what it does is it's saying, yes, I am eligible for an HIV self-test, right? And I can continue to ship them. What it's saying as well is based on the history I gave, right? This was a white man who reports having sex with men, genitals anatomically reports having a penis, sexual practices, oral sex given and received, anal sex top and bottom. So it's saying in addition to this HIV self-test, other testing that would be clinically indicated would be gonorrhea, chlamydia, oral swabs, rectal swabs, and a urine test. HIV serology, hepatitis C. Remember, I put in here that this is a man who has sex with men who's never been tested before, and syphilis testing. There's linkages to local testing clinics where this can be done. An individual could take a screen capture of this. They could print screen. They can also create a sort of printing of this list, which would come onto the GetaKit letterhead, right? Something that they could actually take and the date that they've actually completed this. So this could be something that they took to another clinic, or it could be just something that informs them, right, based on the practices that they're engaging in, that they would want, that it would be recommended as part of their sexual practices to go. So then I hit continue to shipping. We have the ability in Ottawa to ship to the address, right? So it actually will be mailed through Canada Post. Pick it up, and we have said locations where there are actual test kits, right? So somebody could say, I'll go to the sexual health clinic. I could say I'm on site right now, so I'm actually using a computer, for example, at the AIDS Committee of Ottawa or Max Ottawa. Right, and seeing as they have the kits already, right? We wouldn't need to actually send anything. It just says it's confirmed and they can go and get it, or they can say, I already have my kit. And this is the ability for somebody who's ordered a kit or gotten a kit through some other mechanism, if they wanted to actually report a result back. Then you may think, is that going to happen? And in fact, there is sort of one instance where that has occurred. Somebody was unable to actually get themselves linked back through another project. And so they came to us to actually link them for the confirmatory testing because they had a positive result in their self-test. So I'm going to not do this. I'm going to say I'd like to pick it up, and I'll select the sexual health clinic. I hit review. and it gives me the information, which will also be texted to me, and I'll just hit place order. Once that's done, I now have sort of the outstanding little bit here, right? I have this little exclamation mark, right? And it's saying, yes, right, we have this there. You can't actually reorder, right? And it says, please return to this page once you actually have that result that's there. And so it's locked from reordering until we actually distribute the kit to the person. So that's the actual process that it goes through. So what are the outcomes, right, of this? So it's really do we have? Now, I see there was a question. Could GetaKit be delivered to another province? Gatineau, yes, Pedro. Gatineau will be included as part of the Ottawa. So it's the National Capital Region that we'd be distributing to. So for the outcomes, right, what do we have? So we launched this July 20th, 2020. We have distributed to date 2,500 kits. We have an eligibility rate of around 73%, meaning that 27% of people through that risk assessment screener are deemed to be ineligible. The most common item that really started when we initiated this as a pilot is that people outside of Ottawa wanted access. And I mean, the first question we have was exactly that, right? If somebody's just in the Gatineau region, so part of the National Capital Region, could they get access? And originally it was a no, but now through the expansion to across Ontario plus the National Capital Region, it's really dropped. But we still do continuously get requests coming in coast to coast, all the way up through the territories, people accessing GetaKit and seeking orders, right? And so this is going to deem them ineligible. Now, with the expansion, at least to Ontario, the most common reason that people are deemed ineligible is due to reporting symptoms. They're symptomatic and they want to do testing for HIV to rule it out. Due to the fact that HIV could be one of many differential diagnoses, right? One of many different causes. In this case, we say you do have symptoms. We appreciate you wanting to do HIV testing, but right, whatever symptom you have could be something else. This could be COVID, this could be syphilis, this could be lymphoma. Like, please go and actually be seen by a clinician who can do an assessment and give you some more information on this. So that is the reason people are out. For priority populations, so talking about, right, what percentage of people belong to the groups most affected by HIV, it actually came to, in total, somewhere around 77-78% of people who actually access the test kits belong to priority populations. So of that, and this is going to be right, the vast majority of the GBS and MSM, so gay, bisexual, and other men who have sex with men, are going to report being cisgendered, are going to report being white. And so it's just how many people, right, sort of were not, didn't have a single characteristic that put them into a priority population. And it was, like I said, it's less than a quarter who didn't actually fall within those groups. Trans, you can see ACB, so it's around 1 in 5 test kits being ordered by people who belong to African, Caribbean, or Black communities. Indigenous, 2%. People who report drug use, 8%, and sex work around 9%. First-time testers overall was around 28%, so just over 1/4 said they had never been tested before. And there was an additional 7% who actually indicated they were uncertain if they'd ever done an HIV test in their life. So putting that together, right, bringing that up to 35%, we really have around 1/3 of the sort of 2,500 people who went through who said they had never been tested before definitively or uncertain if they'd ever done an HIV test before. For priority populations, this was very similar, 26%, so still just over 1/4, 6% uncertain. So that coming to 32%, almost exactly 1/3 of the members of priority population saying they'd never done an HIV test before. So a single HIV test, at least this becoming the first one they'd ever done. For positive results, we have a current positivity rate of all tests distributed. Then you can see under the test results, so in the bottom left box, 61% reported. So we're getting just under 2/3 of people actually coming back to report their results to us. So of all of those tests, and that would be the denominator of 25, 28, right, we have a positivity rate of 0.36%. And then of just those being reported, we're sitting around 0.67%. Negative, 31% prefer not to report. And so this is people who come back and say, yes, I'll give you a result, but I don't want to actually tell you what it is. 1%, and then an invalid rate of 19%, which I'll speak to a little bit more. So moving into the positive results. So we have had 9 reported to date. All 9 have done confirmatory testing. We brought them in for 4th generation serology. 8 out of 9 were true positives confirmed as new diagnoses. Sorry, no, not as new diagnoses. 7 of 8 were new diagnoses. 1 was a previous diagnosis. And so there are the positivity rates, the locations all across Ontario, Ottawa 5, Toronto 3. This makes sense as we've started in Ottawa, even though the population in Toronto and the number of diagnoses is higher. Sort of expansion into Toronto only started about a year ago and really been expanding up aggressively since. But it makes sense where Ottawa is really where we started, have done the bulk of the actual linkage and awareness that we're still getting more testing being done there. For risk factors, 6 were gay, bisexual, or men who have sex with men. 2 were female. 1 was a Black woman, and the other was a woman who reported that her male partner had sex with men. For last testing, 6 out of 8 reported their last test was greater than 12 months ago. So I said 1 was not a new diagnosis, and this was somebody who was previously diagnosed. There's 2 ways that this could go, and I'll just explain those 2 ways and then sort of what we had. Some people are confused on the test being an antibody test. Individuals, and this is constant in presentations and sort of correspondence we get, and people who are HIV positive think that they will be negative on the test due to the fact that they have an undetectable viral load. So a bit of confusion around viral testing versus antibody testing. There's other people though, and I have seen this sporadically, not frequently, but sort of since working in sexual health over the last 18, 19 years, do see this occasionally. People who don't have sort of an accurate scientific understanding of HIV and its natural history, people thinking they can cure through medications, people thinking they can cure through religion, through voodoo, through prayer. And so this was somebody who had attempted to pray to get rid of their HIV, had believed they had been successful, and wanted a self-test to actually test their antibodies, trying to see what the outcome was. Right, unsurprisingly came back still as positive. And so is that a waste of a test? Not at all in my mind, right? This is somebody who was no longer using medication, whose understanding of HIV, right, needed a bit more information and support and re-engagement with care. And so if GetaKit is the way that we can actually get some people, right, re-engaged in care, re-engaged in their health for HIV management, then I think that's also a success. So although it wasn't a new diagnosis, it was an exceptionally important piece for, I think, public health, also for that individual, their health, their family and community's health, right, for us to be able to link them back. So contextualizing uptake, I said our positivity rates coming in around 0.36 and 0.67, right? If you look at 2011 to 2019, you can see the sort of point of care positivity rates across Ontario ranging, right, sort of between 0.32 at the end, highest 0.69. So it's really putting us in comparable. In fact, compared to 2019, right, these are above. For distributions and numbers, so of those 2,500 kits, remember the last 12 months have really been the provincial expansion. So in the last 12 months, we have distributed almost 2,100 kits. And if we took the actual number of point of cares, so the rapid HIV tests that were distributed in 2019, GetaKit is now running basically around 11% of, right, all point of cares that would have been done pre-COVID, right? And this is just with us still moving through the expansion. And we have continuous sort of increase uptake daily as we move along. So contextually, right now, 1 in 10 point of cares, at least based on the denominator from pre-COVID, would be done through this project and program. And our positivity rates are really quite comparable with other targeted HIV testing initiatives in Ontario, at least. Race and ethnicity-based data. So this is ACB, so African, Caribbean, Black, compared to white, and this is not Black, Indigenous, all people of color. In this case, it was really looking at people who identified, right, as Black versus white. Were there any actual differences? One striking differences, and this is really just on bivariate analysis of chi-square, looking for significance. One thing that did pop up was, you can see there is a higher percentage, right? For white, we have 27% of people who identified as white reporting previous STIs versus 16% for members of ACB communities. For prior HIV testing, you have 79% among people who are white versus 70% for, right, members of ACB communities. Prior testing, if we look specifically within that, is just gay, bisexual, and men who have sex with men. The numbers actually creep 1% in either direction, making that disparity slightly higher. And then results reporting, right? We have almost 2/3 of the white participants reporting results back, where just over half among members of ACB populations. So we have, we actually look as well as the positivity results reported by ACB versus white, there's no difference. So there was actually no difference in positivity rates between members of ACB communities versus white, despite much lower reporting. Meaning that, right, it takes fewer results to actually identify more positives, which is not surprising. And again, it's bringing in that idea of layering on social disparities, layering on social risk factors for, right, groups that are disproportionately affected by HIV. This also raises some interesting points, I think, for some other items, right? And just permit me to go on a bit of a tangent here. A lot of our PrEP guidelines currently really are focused on people having previous diagnoses of STIs, showing that for Black men, women, right, members of ACB communities, we have lower rates there, meaning that that actual risk indicator is most sensitive for people who are white. But as soon as you move out of white populations, you get into Black populations, the risk factors we have are not necessarily as good. The positivity rates are matching in the end, but right, when we look at who we're offering PrEP to, we have disparities based on current guidelines, right, which we're hoping to update sort of imminently. Prior HIV testing and access is also lower, right, as we move into ACB populations. So for sex and gender, prior testing, unsurprisingly, we have higher rates of HIV testing among people who identified as male. And it didn't stratify out here based on sexual orientation, right? But this is just in total, like 64% of males versus 40% of people who identified as females. And this is people who identified. So within this categorization, the way I sort of very roughly put this together here, and I will with full admission say that there's problems with what I did. It's anyone who identifies as female or identifies as male, whether this is trans or cis, right, all of that would go into it. Previous testing within the last 12 months, right, very similar sort of outcomes, but right, closing the gap a little bit. Prior STI diagnoses, actually, right, the numbers are higher among male, like just numerically, but non-significant for the actual chi-square testing. Rates of sex work, slightly higher, 2% higher in female, but non-significant in the chi-square testing. And results reported, there is a difference. Again, you're seeing higher reported results in males compared to females. So again, showing that this is giving access to a bunch of women who had never been tested before, or individuals who identify as female. People who have identified as female, right, the testing history is also more remote. And the result reporting is again lower, right? And where that becomes a problem for our system, and this is also a problem for the GetaKit system, right, for members of ACB communities, and that lower reporting, right, is that a lot of the offers of PrEP based on priority population really occur when somebody reports a result back. So that follow-up and that linkage to care among groups, right, who are not reporting the results back may fall off a little bit. So for some next steps, where are we going? First, we have currently on the site, there is an STI screener. So that entire risk algorithm we went through, people have the ability, they don't have to register, they can go through it, and it will give them the recommended test list. This has two utilities. One is somebody could go through and say, what are the tests that I myself personally want based on my reported practices? It is dynamic, so as you change any question, it's going to modify the actual test list, right, that people are doing. And you can see the age categories 15 and under, 16 to 29, 30 and older, and really sort of following some of the screening guidelines for gonorrhea and chlamydia in relation to youth, right, as well, that were sort of confirmed more recently by the Canadian Task Force on Preventative Services, right, saying that, right, youth need additional screening for gonorrhea, chlamydia. So all of these questions are really putting people into risk stratification and levels. So that's there. The other thing this could be used for is clinicians in their office, right, saying, I'm not entirely certain what I need to be offering, or I don't know what this person wants, or I'm not comfortable, or the patient's not comfortable. this could be loaded and the individual could actually go through this on a tablet. They could go through it on your laptop, on your computer right there in the office, get to the end and then just follow through, knowing that this has what I would say is near perfect implementation of Ontario and Canadian and CDC guidelines for recommended screening. Now, a couple other items for next testing. Where we are caught in Ontario for full distribution of mail-out and at-home STI testing are one, the Public Health Ontario lab accreditation quite specifically says, as you can see, at-home patient collected specimens not accepted at PHO, so the Public Health Ontario laboratory. So somebody who does a self-gonorrhea chlamydia test, it is permissible in a clinical setting, but the lab does not actually have any accreditation to do this if the person does it at home. This is being done where everyone, I think, is pretty well aware of that. The problem with it is taking this up as practice. You don't know the validity of it. It's a NAT, it's a PCR-based test. It's likely going to be the same, but without any sort of validation, we don't know that. These specimens could be canceled, and again, we're not entirely certain what the validation is going to show, although I have my sort of suspicion that it's going to show no difference. The second is this is a serious mouthful of a law, but the Laboratory and Specimen Collection Center Licensing Act, which is what regulates testing laboratories in Ontario. It says it can only examine specimens from humans if, and then you can see there's that big long list going through. And basically the third word in almost every single point is at the request of. And so there's also the requirement that computers, automations, GetaKit type systems, is that an actual medical practitioner? Is this a dentist? Is this a midwife? Is this a nurse practitioner, such as what I am? Am I requesting? The system is requesting based on current guidelines. And so it's working with that. Now the GetaKit system is allowed to actually be implemented. And so our next steps are one, the STI validation, which we will be starting imminently. We're just waiting for the final approval from our research ethics board. And we will compare the sensitivity and specificity of people who come to the STI clinic, where they will do 2 at-home swabs, they will do 2 in-person, in-clinic swabs, and they'll be sent off for comparison, determine error cancellation rate, sensitivity and specificity of those that are actually processed, So that will give us that validation study to say whether or not at-home testing is non-inferior, which is really what we have powered this to determine. We will also move to sending out STI tests based on the algorithm so that you can see the system itself is already calculating risk. It's already determining the full comprehensive package of STI and HIV testing and hepatitis C, so STBBIs, sexually transmitted and bloodborne infections that people would need. So it's really just moving into, once we have the validation, we will be able to actually send out all of these tests. And this will come with sort of a second little box. So you'll get your HIV self-test box we've looked at now, but there's also an STI test box. And within that, you would have the actual PCR tests, the self-swabs people could do at home. They will have lube, they will have condoms, they'll have some information sheets, the requisitions, specimen bags, that these could be taken to local laboratories where these could actually be passed along to the Public Health Ontario lab, to PHOL, for processing, So these are really our main 2 areas of expansion. In doing all of this, what have we learned? A ton. We learned an absolute ton. First off, I'd say good news is it showed that people do use this, good demand, supports are needed. The demand that we've seen, I'm going to say COVID actually probably increased the demand due to the fact that that decrease in access to testing at different times, sort of an average across 2020 of 26%. This likely drove some people over to self-testing. COVID as well also really normalized and got people being aware of self-testing, with whether this is the Lucira PCR test that we sort of distributed through GetaKit, the at-home PCR test we were offering, or the RATs, the rapid antigen tests that people are much more aware of. It's just sort of normalized testing, normalized self-testing a bit. So I think COVID actually probably drove up the uptake slightly. We had nearly 3/4, belonging to HIV priority populations. And it showed that the demand for HIV self-testing is not exclusive to Ottawa as we started. In fact, it's not even restricted to Ontario, And it would not be a problem aside from funding for GetaKit to be distributing across the country. And that would come with a corresponding demand. There are still, though, registration barriers. It is an online system. There are many questions. There's lots of words. You need to have good internet access. You need to have an address to mail to, or we need to have curbsides picked up. Rural and remote communities, right? This is possible, but you'd have to have kits pre-distributed basically to, right, these remote communities, so people could go to a local center, but you then have associations, right, of people being able to get this private and confidentially. Results positivity rate good, as I said, on par with other targeted initiatives. The invalid rate is much higher than we would have expected. We had been running in sort of upwards average around 19%. We are down definitely since adding more interventions and initiatives. These being following up more directly with people who report invalid results, giving information at times where people seem most susceptible to actually receiving it, right? Creating that workstation, creating on the workstation print visual information to help people follow the steps and do the test. And with that, we've seen it come down. But really, I think what GetaKit is demonstrating in relation to the invalid results is that people who order and do self-tests in this way are different from those who have done it in controlled settings. Most of the HIV self-test studies that we've seen are, right, where they actually do the validation, are done in clinical settings. And I don't think the person who does a test at home by themselves, and I think this sort of demonstrates it, are the same people who can book an appointment, show up to the appointment, and do the full test while somebody is observing them. They may be paying more attention, whatever it happens to be. If I can sort of infer anything from my ability to build IKEA furniture, I build it till the drawer doesn't open, and then I go back and look at the results. But the problem with this test is you've already done it. It's yielded an invalid result, right? And so you can't go back to that point, undo a step, and actually have the test work. And so that's where people end up reordering. We have very few people who end up with 2 invalid results in a row, although it does occur in some instances. Reporting, it does happen, but there's no incentive, right, for people to report negative results. We do talk about PEP and PrEP and linkages and retesting, but this isn't necessarily there. Positive results, we are getting reported back. So some concerns that people would have, right, are people actually going to return and report results? We are seeing that they are coming back, and right, our confirmation of 100% confirmatory testing and linkage to care. And then I think another key thing from this is we learned guidelines can be automated. You can, through, right, the correct computer programming, you can actually automate clinical decision-making. And anything that falls out of clear-cut guidelines refer into in-person care, which works for a lot of times with, right, screening. We have long said most sexually transmitted and bloodborne infections are asymptomatic. Don't rely on symptoms for testing. And then what did we do in COVID? We really said, right, you can't get access for screening. We just don't have the capacity. And so, right, everything turned around. And so here we have, right, GetaKit offering potentially a way to actually bridge that. So with that, I had questions and comments. I guess I'll, in the remaining 8 minutes, open it up. Stop sharing. So
Thank you, Dr. Byrne. That was a fantastic presentation. Really interesting. For webinar participants, please enter your questions into the chat, and Dr. Byrne will be happy to address these. I'm going to start off with an easy question, I guess, or maybe difficult. Very, very interesting, and you're obviously filling a need, and you're accessing populations that really need this testing. What do you make of the fact of the low reported positive rate? And I want to ask you about, you said 9 individuals were reported positive, but only 61% of people reported their results. Is that right? So there's, which is good. It means that there may be a lot of people that aren't reporting their results. But what do you make of that? And how do you contextualize that information?
So I'm going to answer this in a very roundabout way. So we, as part of, during this, Health Canada, the Ministry of Health came to us and said, could this system be tailored to screen people in and out of using molecular, so PCR COVID self-tests? We said, we don't see why not. We tested it. We distributed 7,000 of these tests across Ontario right during the start of Omicron, which actually meant that they moved quickly. We have a similar reporting resultant rate, and we actually had a team of nurses who were following up and calling people, going through all the tests. We did identify through COVID that a subset of people had positive results that they hadn't reported back to us. So, right, taking this from COVID over to HIV, is that possible? It definitely is. I would imagine that there are probably some people who had positive results that just haven't felt comfortable or wanted to report back to us. One thing we've identified, though, with the people who do report the results is that once they have a positive result, they do actually want support. And it's interesting at that point, they want somebody to talk to, and they want somebody to guide them through the next steps because they're not entirely certain. They seem to trust coming back to us a bit more than just scouring the internet based on the unknown reliability and validity of that information. So we do have it. So I think COVID gives us an idea that there's probably some who haven't reported, but I think there's also a very big difference between a positive COVID test result, which people may be less apt to say, what do I do next? Like, that information is all over the place, versus the HIV saying, right, what does this really mean to me? What does this mean for my life expectancy, for my quality of life, for everything moving forward for my job? Still an incredible amount of misunderstanding and misinformation about HIV. So I think that 9 is the minimum. You're right. There's probably some more, but I don't think the number will be much, much higher. Okay. But the positivity rate does match what we see for point of care testing in Ontario.
Mm-hmm. Mm-hmm. And in terms of expansion, what's next? I mean, you mentioned next steps, but where do you see the sky's the limit with this, right? I mean, you could go national. You could. What about Hep C? I mean, lots and lots of things that you could add on to this. What do you see as the low-hanging fruit here?
So, like, what I really want to see as next steps is the implementation of STI, which we are going to be doing quite imminently. This could be expanded basically anywhere, but STI is a bit different because you actually need to get treatment, right? So expanding STI more at a provincial or national level, you need to have local centers where people can come in. We have seen a lot of virtual HIV prevention services, PrEP clinics becoming available. There's utility to that in getting medication, but it seems to be with some of these virtual PrEP clinics, as soon as somebody has a positive result, what do they need? They need an in-person clinician, right? So I would think for that, we would also have to link with local clinicians, local centers, where if somebody needs vaccination, if somebody needs treatment, and I mean, syphilis is an injectable, gonorrhea treatment is an injectable. And so we need places where people can actually go. It's not just faxing prescriptions to local pharmacies. So there would need to be in-person linkages, but it cuts down the ability, of screening. Like, I just think that pre-COVID in the clinic I worked, we would see 20,000 patients a year to get 4,000 cases, right? So it's like we were seeing thousands upon thousands of people who had absolutely no infections. Then this is a way that you can actually divert and really focus on the in-person care, being people who are symptomatic, people who are more complicated, people who have access barriers to the internet. So low-hanging fruit, adding in other rapid tests, the Hep C point of cares that you talked about. Hopefully syphilis point of care tests will become something that's available. The limitations to that, it's an antibody test. Anyone with a historical infection is going to screen the thing positive, but really figuring out how to stream that in, I think it becomes simple. And how to really get, I mean, a big focus I think we have right now is how do you get people with undiagnosed infections linked to testing. And when you have the vast majority of these infections being in priority populations, you can test those groups and get a high yield. But as we move into that sort of remaining people, we need to actually do a little bit more mass public population testing to get it. And so this is a way to not inundate the health system with people who are exceptionally low risk, where you need more low risk people tested to get those few infections. So it can also be sort of a low barrier, low burden on the healthcare system mechanism to maybe get some of those people who aren't gay men, who aren't people who use drugs, who don't belong to these other risk groups, to get access to testing.
Patrick, that was fantastic. We just have 1 minute left. Can you pull up the Q&A? There were several questions there that people wanted to ask, and maybe if you want to just take a second and talk about accuracy. How has the test accuracy been measured review the principles of the test. Can you do that in 30 seconds?
I can. I'm going to start at the bottom. Special validation considerations. So that's one of the things that we want to see. How many are canceled? How many come back with issues? That's one of the things we will be tracking because we really want to know if the sensitivities are different or if a huge number of them are canceled. That's really one of the things we want to look at. For the next question on people not, or why do people use self-testing? I'm not sure, and very quickly, I don't think I can answer it. Max, perhaps you could email me because you have a good list of very specific questions, and I think you work very precisely in actual STI testing, so I would love to have more discussion on this. And Derek, that is an exceptionally good question. I'm not just saying this because I know Derek, but yes, you are required to reorder. You are required to put in a test result. So reordering actually as part of the system requires a report right from sort of basically something else. But prefer not to report as always.
I think we have to call it quits, but I want to thank you very much for an outstanding presentation for this IUCD webinar. Please stay tuned for more upcoming webinars, and IUCD Canada is delighted to welcome you today. Thank you for the presentation. Okay, take care.